The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to this presentation from HSG about the 2021 proposed rule for the Medicare physician fee schedule. We hope you'll find this information to be beneficial, as there are a number of items that have gotten attention recently regarding the upcoming proposed changes. So without further ado, let's go ahead and start the presentation. During this presentation, we'll endeavor to give you some background about the physician fee schedule, a summary of the proposed changes, and some of the significant changes for employer-provider networks and the potential impact if they are passed into the final rule, which won't be completed until closer to the end of the calendar year. So just a quick background, the physician fee schedule determines reimbursement requirements and rates and applies to payment for services provided by physicians and other practitioners at all sites of service. The 2021 proposed rule was released on August 3rd and was published in the Federal Register on August 17th. The entirety of the proposed rule can be found at the link shown on the screen at this time. Public comment period is currently open and will close on October 4th. And the final rule which is usually released the first week in November and takes into account the number of comments received, is anticipated to be delayed until about the 1st of December due to CMS's COVID workload. Of note, CMS takes public comments very seriously, and in past proposed rules have had significant changes between the proposed rule and the final rule. So, even though the proposed rule is rather extensive, we won't know what's actually put in place and made effective on January 1st until the release of the final rule, which may not be until the 1st of December. Considering a number of the proposed changes will have significant impact, we felt it prudent to present the content of the proposed rule, discuss some of the potential implications and where we see this going, so that everyone can prepare now, because there may be some significant issues that arise. The 2021 proposed rule had the same major themes as last year's rule, with some of the initiatives being generated in response to the desire to reduce administrative burden of healthcare, the so-called Patients Over Paperwork initiative that CMS has introduced a couple of years ago. There's also the desire to improve the accuracy of outpatient E&M coding and payment processes, and again, to decrease the administrative burden and complexity, and the desire to consider the impact on evolving healthcare delivery to create a system that results in better accessibility, quality, affordability, empowerment, and innovation, all of which are CMS areas of focus. So if we look at the summary of changes over the next several slides, the conversion factor is proposed to decrease to 32.26. This is a decrease, an absolute decrease of $3.83, and a percentage decrease of more than 10%, about 10.6%, compared to the 2020 conversion factor. We'll talk about that in more detail in a few minutes. The office E&M coding changes that were part of the 2020 final rule are continuing to be pursued and would become effective on January 1st of 2021. An area that is new in this proposed rule is an increased wRVU value for most codes. CMS is proposing to make total time spent on an encounter any given day, and medical decision-making complexity, the two tenets upon which coding, E&M coding, is based. This is also consistent with the 2020 final rule. They're adopting or proposing to adopt new time spent parameters by code, and creating the 2 new add-on codes for additional time spent and greater complexity for certain visits that were heralded in the 2020 final rule. Regarding telehealth services, they're making some permanent changes and some public health emergency limited changes that we'll talk about in a minute. There are soliciting comment regarding reimbursement for telephone based telehealth services, and proposing to permit virtual direct supervision beyond the public health emergency. Scope of practice for NPs, CNSs, certified nurse midwives, and PAs is being recognized to be that these individuals can supervise the performance of diagnostic tests. Previously, they could order the test but could not supervise. Only physicians could supervise diagnostic testing, and now they're proposing that this grouping of APPs would be able to supervise diagnostic testing. They're explicitly including pharmacists in the auxiliary personnel included under Incident 2 regulations. And they're making permanent the PT and OT delegation of maintenance care to PT assistants and OT assistants that had been proposed in the past. Regarding communication technology-based services, these are services that are already in place, like virtual check-in, that are non-face-to-face care and not subject to telehealth regulations. So there's a suite of interactions that CMS has approved in the past for reimbursement and RVU credit. And so these same things have now some expanded elements. The first is that consent can be obtained and documented by support staff under general supervision of a credentialed direct care provider. And it's expanded those individuals to bill for online assessment of established patients under the G codes 2061 to 2063, and adds new virtual check-in codes and imaging codes accordingly. Regarding remote physiological monitoring, CMS indicates it'll return to apply this to established patients only once the COVID public health emergency ends. And it clarified existing policies and specifically called out that consent for remote physiological monitoring can be obtained at the time the services are furnished. They do not have to be patients do not have to be pre-consented for this remote monitoring. As far as clinical laboratory fee schedules, the payment decreases were delayed as permitted in the CARES Act. And there's a whole section on appropriate use criteria, which we'll talk about a little bit. But basically, they're extending the educational and testing period through 2021, and there won't be any payment consequences until at least 2022. On the FQHC side, they rebased and revised the market basket to reflect the 2017 base year, and it led to an increase of about 2.5% for that grouping, and the multi-factor productivity adjustment of 0.6% increase. Regarding the Medicare Shared Savings Program, CMS updated the primary care definition for the beneficiary assignment process, proposes to revise how repayment amounts are determined for two-side risk models to make repayment a little less onerous and a little less painful. In a fairly significant move, eliminate web-based reporting mechanisms for the MSSP programs, and concurrently eliminated that with the quality payment program as well. And it replaced that web-based interface with the new APM performance pathway, which accomplishes both the MSSP and MIPS reporting processes, similarly to the web-based interface. However, in moving from the web interface concept, it decreased the number of quality measures that ACOs must report from 23 down to 6. CMS is also proposing to increase the minimum quality performance threshold to the 40th percentile, and is estimating that approximately 95% of ACOs would achieve that score based on 2018 data. At this point, it would be wise maybe to indicate that the proposed rule for the physician fee schedule, the proposed rule includes elements for that, but also elements for the quality payment program, the ACOs, the MSSP facet of the CMS suite of services, and several other elements. So it's not just the fee for service. So the 1,300 or so pages of the proposed rule is not entirely dedicated to the professional fee schedule, but a large portion is. So what are some of these really significant changes that we've alluded to thus far in the summary? And if we look at the conversion factor, which is fairly significant and has already generated comment from AMA and other professional societies opposing that degree of decrease in a single year. These groups have proposed several alternatives. One is requesting waiver of the budget neutrality, meaning that if we're going to increase the RVUs, let the total reimbursements go up so the conversion factor doesn't have to drop as much. This seems to be fraught with difficulty because not only traditionally, but I think legislatively, CMS's work has to be budget neutral. As noted in the first bullet, CMS is required to maintain budget neutrality when making changes in RVUs. So I'm not sure that they can waive that issue. Others have recommended delayed implementation, meaning don't do it this year, do it next year, and allow for organizations and individuals to adjust to that degree of decrease. And then finally, some have argued a phased-in approach, meaning adjust RVUs upwards, but not so much each year, adjust them sequentially over time so that the conversion factor decreases sequentially over time as well. And again, we already discussed this, a $3.83 decrease in the conversion factor, or 10.6% decrease. The last several years, the conversion factor has been relatively constant, as noted on the slide in front of you. But most importantly, the impact will not be uniformly felt across specialties. And if we just look at the differences that are out there, and this is actually from one of the tables in the proposed rule, the range of anticipated impact on total allowed charges by specialty based on the RVU changes varies from a negative 11% to a positive 17%. The most positive examples on the most positive side include a lot of the primary care and medical specialty areas that are on the left-hand column of the slide. So family practice, going up 13%, for instance. There's a grouping that are fairly neutral, meaning no change at all, or plus or minus 1 or 2%. Clinical psychology and clinical social work, no change, and a couple of medical specialties with essentially no change. And then finally, a host of more interventional and procedural specialties with significant negative impact. I mean, this is almost reminiscent of the changes that happened, back in the mid-90s with the RBVS changes, but radiology taking a significant hit, anesthesia services also, and again, some of the procedural, especially high-end procedural areas like cardiac surgery, thoracic surgery, vascular surgery, and others. So not a uniform impact across specialties, a potentially significant impact across specialties, and hence some of the pushback coming from various professional societies. You could well imagine that the American Academy of Family Physicians is probably in favor of this, but we'll leave that editorial comment aside. In looking at the RVU changes being proposed by CMS, CMS's stated purpose for increasing RVU values for the E&M codes include the recognition that there's more effort being expended to provide the same level of care now than compared to the past. They've recognized the added physician responsibilities associated with office encounters, both related to greater patient complexity, but also the increase in non-patient interaction responsibilities associated with any in-person patient encounter. These include things like the significantly increased burden of documentation brought on by EMRs and finally being recognized, and the efforts related to patient care coordination, in addition to having a higher level of acuity. If we look at the proposed change in RVU values by E&M code, and we skipped over in the earlier summary, they're proposing the 99201 code be eliminated because it has the same level of medical complexity decision-making process as the 99202. So there really isn't a whole lot to distinguish it. In the past, there were different elements involving the history and physical examination that would distinguish those two levels. With the elimination of those facets from the 1995 and 1997 coding requirements, there's really nothing to choose from between the 01 and the 02. So they're eliminating or proposing to eliminate the 99201. So the new patient office encounters will go 99202 through 99205. And all 5 levels of the established patient office-based E&M codes will persist. You may recall that 2 years ago, CMS had recommended combining the middle codes, levels 2, 3, and 4. But in the 2020 final rule, that went away, and they're continuing to advocate for maintaining these levels of codes. And that is consistent with the AMA authorities who advise on these areas. But if we look at the differences between the current RVU values and the proposed 2021 values, the lowest level RVU, lowest level E&M codes RVU values will not change. So the 99202 will stay the same at 0.93, and the 99211 will stay the same at 0.18. However, each of the subsequent levels of E&M codes from the 3, 4s, and 5s will increase fairly significantly if this change indeed becomes part of the final rule. The 2 codes at the bottom are those 2 add-on codes, which are not present in the current system, and they are proposing RVU values of 0.61 for each 15-minute increment of time spent, and 0.33 for patient complexity. And we'll talk about those 2 bottom codes here in a second. If we look at the specialty impact of the RVU changes, and note at the bottom, this is a Sullivan-Cotter analysis, there will be 8 specialties that will have essentially no change, and that's about 8% of the total number of specialties. About 21% will have less than 3% change. About 21% will have a 3 to 6% change. 25%, a 6 to almost 11% change. And then as we go higher than that, about 14%, 11 to 16%, 8%, 16 to 21%, and only 3% will have a 21% or greater. I'll be honest, when I looked at the table that CMS provided, I didn't see anybody over a 17% increase, but that doesn't mean I missed it, because from my understanding, the table that was included in the proposed final rule is not all inclusive. So even though there's some discrepancy between both data sources, this does give a better idea of the relative impact across specialties if these RVU changes are enacted. And notice the percentages plus or minus. So this particular table just shows the absolute change and does not distinguish between plus or minus. If we look at certain specialties in the Sullivan-Cotter, analysis. It shows the estimated percent change over on the right. This particular table, however, is predicated that the 2021 estimates for estimated RVU accomplishment will not change. The absolute value will not change compared to the 2019 median. So I'm going from 2019 to 2021 and looking at the impact of changes. This assumes that the coding curves will be identical, and the numbers of RVUs would be identical. Excuse me, the E&M coding levels would be identical, and therefore this would be the impact of the RVU changes. There is a little bit of a difficulty in assuming a one-to-one relationship, based on the change of how E&M coding will be established and determined, and we'll talk about that in just a minute. But this is what they propose the impact will be by specialty. CMS is also proposing to revalue some of the E&M services. These are services that do not have direct effort associated, but have RVU measurements. So end-stage renal disease, capitation services, transitional care management services, maternity services, which is quite favorable considering there's not been an increase in recent years. The annual wellness visits, both the initial welcome to Medicare visit and the initial and subsequent annual wellness visits, has a change in RVU values. ED visits, and then vaccine administration visits, as well as psychiatric diagnostic evaluations and psychotherapy services. So, interestingly enough, the increases in compensation based on the revaluations for the various CPT code do not seem to be sufficient to offset the changes in RVUs. So compensation overall is anticipated to remain constant or slightly decrease for most specialties, while the RVU levels increase. So in many cases, the comp per RVU ratio will change, and in many cases decrease because the change in compensation is less than the change in RVU. So for the calculations across the board, here's the estimated impact according to Sullivan-Cotter when they look at these areas. And even though they've had an increase in ability to achieve RVUs, which likely will change compensation if they are RVU based, the change in compensation will be less than a change in RVU, and therefore result in a decrease in comp for RVU rates. So if a lot of it is absolute value of the RVU, but it's multiplied by a lower comp per RVU rate, is going to have a variable impact on actual compensation received. If we look at the proposed E&M changes a little bit more closely, again, as mentioned, it's consistent with the CPT editorial panel for office and outpatient E&M visits, maintaining all 5 levels for established patients, eliminating the 99201 for new patients, permitting the E&M level determination to be made either by medical decision-making or time, and we'll review both of those in just a minute. Revising the times and medical decision-making processes for these E&M codes, and requiring performance of history and physical examination only as medically appropriate and not as criteria for E&M coding decisions. And again, as mentioned, we'll have new add-on CPT codes for prolonged service times. Here are those 2 new codes. The 99XXX is used to add additional time beyond the base parameter for total time spent on a patient encounter on the same date of service. So this includes all things, the time spent in the face-to-face encounter, the time spent reviewing test results, placing orders, doing documentation in the EHR, etc. And it only applies, however, to the 99205 and 99215 codes when you're using time as a coding determinant. And the reason for this is as you add time, when using time as the coding determinant, you will go from one level to the next up until you get to 99205 or 99215, and then additional time beyond that in 15-minute increments you'll be able to use the 99XXX code. When submitting claims, you'd use this code in addition to the 99205 or 99215 code. The disclaimer here is I'm not a coding expert, and some of this is yet to be determined, but this is the new code for additional time spent for the most complex patient. The HCPCS code, GPC1X, X being a final digit determinant, adds RVU credit for visit complexity associated with patients' single serious or complex chronic condition. This is the code that in the past have been proposed to be utilized more for non-primary care specialties, although it's reportedly not being, primary care is not being excluded from using the code. But this is to recognize the fact that there are certain patients that are more complex, and so adding this code for many of the consultants becomes pertinent. The details for this are still being defined, and again, it may generate an incremental RVU credit of 0.33. When using time, and using time as the determinant for determining the code for the interaction, it's the total time dedicated that the provider dedicated, not support staff, but the provider dedicated to the patient on the day of service. So it's as we were just talking about, the face-to-face time with the patient, time spent reviewing tests, obtaining or reviewing separately obtained history or other consultative documents, ordering medications, tests, procedures, creating the documentation of the encounter in the EHR, communicating with the patient, caregiver, and family outside of the face-to-face encounter, and then communicating with consultants related to the patient encounter or orders. So for instance, if an order was placed and the provider picked up the phone and talked to the consultant, that time can be added into that patient encounter time. There will be documentation requirements for this to annotate within the medical record time spent and where that time was spent. I'm not clear on the details, but there will be a documentation requirement to indicate the time spent on the day of on the day of service. Excuse me. CMS also revised the times associated with each of the E&M codes. You'll recall that up until now, time was only really a factor if most of the encounter was based on a counseling interaction or intervention. I think it's more than half. In this case, you can use time as the sole determinant for the E&M code. But one thing to note, with them changing the times required, if you spent the same amount of time with the patient in 2021 compared to 2020, there may be a lower coding level for the same amount of time expended, which may consequently decrease the total RVUs achieved rather than the anticipated increase based on the RVU value per code. So again, Sullivan Cotter came up with a table, and this was also published in the American Association for Physician Leadership news documents, which is where I obtained it in true transparency. So if we look at the left kind of orange header column, the second column from the left, this is the current minimum minutes per visit, and you'll note that with increasing minutes as increasing coding level. If we look at the 1, 2, 3, fourth column from the left, the 2021 minutes per visit are increased for everything except the lowest code. So for instance, just as we mentioned, the RVUs did not change for a 99202 or a 99201, so also the minutes per visit don't change. So that's a commensurate internal consistency. With the increasing in RVU value, there's also now an increase in time spent to achieve that level. So I mentioned before, if you spent the same amount of time, there might be a significant decrease. If we look at the new patient 99203, which if you spent 30 minutes with a new patient total time on the day of service last year, it would qualify as a 99203. Spending 30 minutes with a patient, however, in 2021 would have that to be coded as a 99202. So again, a lot of the implications of RVU totals going up implies that they'll have the same level of coding level accomplishment in 2021 and 2020. That may not be the case across the board. So I'll just call attention to this because there could be significant differences. Similarly, 30 minutes for an established patient would have resulted in a 99213 code last year. However, that won't change because it's a 30-minute threshold. A difference would be 40 minutes, though. 40 minutes last year would get you a 99214. 40 minutes this year would be a 99213. So it's not a one-to-one. There is a time difference, which may have an impact on RVU achievement. If we look at the other coding determinant criteria, which is medical decision making, recall that the 1995 and 1997 coding criteria included medical decision making, but there was significant emphasis on performances of history and physical examination, which led to a lot of the checkbox kind of emphasis with determining E&M coding levels. So, we had to examine or review so many systems, you had to examine so many systems by both of those criteria, and those two facets are proposed to go away. And the history and physical would just be whatever's pertinent for effective patient interaction moving forward. So if we assume that the medical complexity piece has always been there, and the medical complexity may not change significantly, then there may be little impact on the assigned RVU per encounter when we look at future versus historic RVU productivity data. Keep in mind, however, as we get and we'll review the proposed medical decision-making process here in just a second, some of the EMR templating that currently exists are extremely focused on the checkbox technique and perhaps not in so much as the impact of medical decision making, which often to get thought processes down, looking at differential diagnosis and all required free text comments. And so we may not be very good at emphasizing medical decision making within our current documentation process. So this might need to be improved at least a little bit as we look to the future. This could create both an education and an audit issue. However, my take is, well, let's just go ahead and look at the proposed E&M coding criteria when we look at medical decision making. And for those of you who don't have a magnifying glass, by the way, you can access this at the link at the bottom of the slide and look at it. No matter how I tried to display it, no matter how I tried to break it down, it just wasn't elegant. So I'm going to recommend that you just go to the website and download it for yourself. But basically, the chart in front of you, the coding levels go down the left side with increasing complexity going from the top and all the way down. And there are basically straightforward decision making for an O2 or 1-2, low level of medical decision making for an O3 or 1-3, moderate in O4 or 1-4, and high in O5 and 1-5. And then these, the levels are determined in each of three categories. One is the number and complexity of problems addressed. The second is the amount or complexity of data to be reviewed and analyzed. And the third is the risk of complications and or morbidity or mortality based on patient management with these levels of problems. The left column is fairly straightforward. So for an O2 or 1-2, it's one self-limited or minor problem. For an O3 or 1-3, two or more self-limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury. Moderate requires one or more chronic illnesses with exacerbation, progression, or side effects of treatment, or two or more stable chronic illnesses, or an acute illness with systemic symptoms, or an acute complicated injury. It's not until we get to the high area that we may have more difficulty in achieving the number or complexity of problems, because at that level, you have to have one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. So the severe nature um, in an office-based setting can make this a limiting category. Or you have one acute or chronic illness or injury that poses a threat to life or bodily function. The whole life, limb, and sight kind of complex patient. And again, for most of us in a office-based environment, we would encounter these individuals on a relatively infrequent basis. So just on the surface of that alone, I might anticipate that level 5 office-based visit might have a decrease compared to the prior coding curves. We're going to skip over for the moment the data to be analyzed, because it's a little bit more time consuming, and we'll leave that for your review. But if we look at the risk of complications, and I'll go back to the level 5, it's a high risk of morbidity from additional diagnostic testing and treatment. So for instance, drug therapy requiring intensive monitoring for toxicity, usually not in an outpatient environment. There is the decision making for emergency major surgery, decision for hospitalization, meaning that the degree of exacerbation leads to the recommendation for hospitalization, or the decision to not resuscitate or de-escalate care because of poor prognosis. So a little bit more difficult in both of the categories we talked about in getting to that level 5 patient. I would suggest that you go ahead and download this, take a look at it, and consult a coding expert. There may be some changes in our coding curves moving forward, just based on what I perceive medical decision-making criteria changes to be. All right, so that's most of the E&M coding and RVU credit aspects, which frankly we think will have the greatest impact on employee provider networks. And we should really review these first to educate our staff and especially our providers on the potential upcoming changes and how we document and how we determine E&M coding levels, but also an analysis to determine what might the impact be if all these RVU values increased as proposed. So for instance, a majority, I think it's 60-some% based on a recent survey of provider compensation models are productivity based and therefore by proxy RVU based. So if we're going to have increased RVU and RVU credit, what does that do to our compensation, even if the rates start to change? Because many of us don't necessarily change our conversion factor rate annually, but I think this should require at least an analysis of what the impact might be on the budget, on compensation levels, and on fair market value and commercial reasonableness with these kinds of changes that are being proposed. So there could be a lot to do over these next few months, and it might be prudent to do it proactively as opposed to waiting till December and then trying to figure out what the impact's going to be by January 1st. Big stuff, big stuff. Now, the other area that was anticipated to be huge in the upcoming physician fee schedule is what would CMS do with all the wave telehealth areas, and what might linger and be projected as a permanent change for the future. And frankly, from my perspective, the answer is not much. We didn't get a whole lot of great answers out of this. So in the proposed rule, CMS is proposing to have 9 code areas be made permanent additions to covered services for Medicare fee-for-service patients. The first 2 up there are those 2 add-on codes that we just talked about that are new for this year. But then group psychotherapy, neurobehavioral status exam, care planning for patients with cognitive impairment, domiciliary rest home or custodial care services, these are chronic care codes, and then home visits for established patients are all being proposed to be permanent additions to covered telehealth services for Medicare fee-for-service patients. In addition, CMS is proposing to extend through the end of the calendar year in which COVID public health emergency ends 13 codes that are currently covered and waived, and they're listed there. What that means is that if the COVID public health emergency ends in, let's say, February of 2021, instead of ending immediately, these areas would be extended through the end of calendar year 2021 and be covered as they are now. So notable difference between the permanent and the PHE only are the emergency department visits and the nursing facilities discharge day management, which will be carried through the end of the calendar year. The psych and neuropsych testing also would end with a PHE conclusion. CMS states its intention to discontinue patients for audio-only visits, the so-called telephone encounters, as expected and as they had previously said they would. However, they are soliciting public comment about whether CMS should develop coding and payment for these services in the long run and what that might look like. One of the reasons for this is this has been very popular during the COVID pandemic. And there are Medicare eligible beneficiaries who may not have access to video encounters. And so for the convenience of Medicare beneficiaries, as well as those who are providing care to those individuals, there's some thought that perhaps there should be perhaps a reduced payment or some ongoing payment for telephone interactions in lieu of face-to-face encounters, especially recognizing the barriers to care that many Medicare patients might face. So there is an open door for public comment, and CMS will take that into account. It's unlikely to impact the 2021 final rule, but may impact future final rules. In a significant move, CMS is proposing to revise the frequency limitation on the subsequent skilled nursing visits via telehealth from once every 30 days to once every 3 days. This is felt to be huge in the chronic care realm, or long-term care realm, I should say, to allow telehealth interactions that frequently, to allow greater interactions about and with skilled nursing facility residents. And then finally, in the telehealth realm, CMS is proposing to extend the policy that direct supervision of care can be accomplished virtually using real-time audio video communication with supervising practitioners, and that would be continued through 2021, regardless of when the public health emergency is concluded. This was something that was initiated just for COVID to try to protect both individuals from increasing exposures, but it's found that this is likely a viable way to provide direct supervision in lieu of physical presence. The last area that I just wanted to touch on is something that has been out there and many of us have kind of ignored, and that's appropriate use criteria. Appropriate use criteria applies to advanced imaging techniques, which are listed on this slide, and actually came out of a Medicare Act back in 2014 that was to increase the rate of a quote appropriate end quote advanced diagnostic imaging services provided to Medicare beneficiaries. And frankly, the American College of Radiology has done a lot in this area um, to work on guidelines for utilization of advanced imaging techniques. By design, what's proposed in this physician fee schedule rule is that the system would be designed that at the time a practitioner orders an advanced diagnostic imaging service for a Medicare beneficiary, the ordering clinician or clinical staff acting on the ordering clinician's behalf would be required to consult a qualified clinical decision support mechanism, or a CDSM. CDSMs are electronic portals through which appropriate use criteria can be accessed, and the CDSM provides a determination of whether the order adheres to the appropriate use criteria, um, or if it's not applicable, meaning there isn't something assigned to address the patient's clinical condition. So if it does not adhere, then a consultation must take place at the time of the order for the imaging service in defined settings and parameters. In addition, if there are ordering clinicians whose ordering patterns are considered outliers, meaning you're not conforming to the colleagues' curves, then you'll be subject to prior authorization. So this is a way to address prior authorization without in a less, at least purportedly, less onerous process. So you go into the portal, you put in the information, and you get approved, as opposed to going through other types of pre-authorization services. And if you're ordering curves or outliers, then you'll need to get straight pre-auth. This program was supposed to be fully implemented on January 1st, 2020. And claims that fail to append this information would just not be paid. So there's a whole section on appropriate use criteria and the implementation. There may be a bit of a delay coming out in the final rule, but this is coming soon to our practices. If it goes according to its previous implementation timeframes, this would be a year from this coming January that it would be implemented. We all would have to have operational services in place to be able to accommodate this change. And so we felt that it was at least worth pointing out that this is out there. It's been in the works for a while. It's been in evolution, but this may be something that will impact advanced imaging orders for our Medicare fee-for-service patients just about 15 months from now. Again, this was not meant to be a detailed presentation, but just to tell you that appropriate use criteria really will start to impact our billing process. It will not be in 2021, but may be as early as January of 2022, and just something to keep on our radar and to work on, so that our operational processes can keep pace with this evolving issue. With that, we'll conclude our presentation. We hope that this information was helpful and valuable to you, and having it in one place might make it easier to digest. This is no substitution for looking at the proposed final rule in and of itself, but at least we'll give you some background to get started, and at least understand a little bit better of all the things that you're hearing a whole lot about in commentary and in the literature at this time. So thank you very much, and again, we hope this and our other presentations will be helpful to you, and look forward to our future interactions.